Hello, good morning everybody. It's a pleasure today to have our first webinar, CI for meningitis from A to Z. This webinar is organized by the Egyptian Society of Cochlear Implant in association with AutoAlex. And today we have distinguished panelists. All of them are very known figures in CI in Egypt. By alphabetical order, Professor Adel Khalifa, Professor Ahmed Khater, Professor Mahmoud Mandoor, Professor Mohammed Mubashir, and Professor Rashad Ghunaim. All of them are surgeons except for Professor Ahmed Khater, who is an audiologist, an eminent audiologist and audiovestibular medicine. So today we are going to start our talk, our presentation by epidemiology. We are not going to start by surgery, by audiology, by epidemiology. We can see that bacterial meningitis is one of the most common causes of acquired hearing loss in infants and children. And it's common in all countries, most of the countries, but some countries succeeded in reducing the number of meningitis in their countries, where others didn't. So my first question will go to Professor Adel. Why do you think that some countries have reduced their incidence of meningitis and others didn't? What could be the factor for that? Professor Adel?
Yes, thank you, Dr. Fathi, for this invitation. Actually, the answer is this variation in instance is due to the policy of compulsory vaccination against meningitis in these countries. There are three known vaccines for this disease. The meningococcal vaccine against meningococcal meningitis, Neisseria meningitis, and the pneumococcal vaccine against pneumococcus, and the HIV vaccine against Haemophilus influenza. In countries that gives all these vaccines, the incidence will be very low. On the other hand, in countries that gives only the pneumococcal vaccine and ignore the other vaccines, the incidence will be high. So we recommend to do all these vaccinations to reduce the number of meningitis in our countries.
Okay. So in Egypt, as you all know, in Egypt, we have only compulsory vaccination for Haemophilus influenza. We don't have
for pneumococcal vaccine.
We don't have for pneumococcal vaccine or Neisseria meningitis. So we have we have to work hardly with Ministry of Health and
yes,
our pediatrician to enforce this compulsory vaccination. So by the same talk, Adel, the incidence of hearing loss after meningitis is variable from 5% to 35%. Is there any reason for that? Why some people got hearing loss, others don't have hearing loss? Do you have any explanation?
I think that this variation in instance of sensory hearing loss after meningitis is mainly due to the corticosteroid treatment, steroid treatment with antibiotics. We don't give antibiotics only, we give corticosteroids also with antibiotics to treat this disease. Many expert opinions and many papers recommend routine using dexamethasone in treatment of meningitis besides the antibiotic. The recommended dose here is in the children 0.15 milligram per kilogram for every 6 hours for 4 days, and in adults it is 10 milligrams 4 times a day for 4 days. So we recommend corticosteroid mainly to be besides the antibiotic treatment in meningitis to reduce.
So you are saying that the steroids had make a difference in the management of meningitis. One thing it's no worse to say that they found if you give the steroids half an hour before the antibiotics, the results of hearing will be far better.
Yes. Early steroid therapy is very important.
Now I'm going to ask Professor Mubashir to present a case, and he's going to, and then I will ask him what lessons we have learned from this case. Professor Mubashir.
Yes. Assalamu alaikum. Thanks for Prof. Fatih for his invitation. Our case presentation is female child, exposed to meningitis at age of 4 months, with persistent fever, not swallowed treatment. She went to her parents took it to the hospital and was diagnosed as meningitis. And she stayed in hospital for 2 weeks and received medication and discharged without any etiological investigation. Okay? But without any neurological consequences. After another 4 months, at 8 months, her parents noticed that she is not responding to sounds around her. So they asked advice, went to a audiologist. She did ABR, diagnosed as severely profound sensory hearing loss. They advised for her hearing aid. She wore an hearing aid, not did benefit. So asked advice again. So the next advice for audiology advised for or recommend for CI. We received this patient, and after 1 week or 2 weeks, we did her some investigation, of course, CT, MRI, audiology setup, and we chose, I remember the left ear because it is better in radiology. And for audiology and audiological tests and radiological tests will be presented by Dr. Fadel and Dr. Mansour.
So, Mubashir, what are the lessons we can learn? What are the lessons we can learn?
We did CI, posterior tympanotomy, drill out basal tail skeleton tonight, and then insert, I think, a middle, I think, electrode, formal electrode.
Okay.
And they doing well now, doing well, very well.
Okay. So what are the lessons we learned here? We learned 2 lessons here. The first is that the patient was discharged from the hospital without having any audiological test. And
yes.
that the parents also, they are the one who noticed the hearing loss after 4 months from the infection, which is a very long duration. The second lesson we learned, this is, the first one I can consider it as a fault of pediatrician. The second lesson we learned that the audiologist, despite that the patient or the infant has bilateral severe profound hearing loss, he gave him a hearing aid for 6 months. And this 6 months, of course, it's very, can cause a lot of ossifications and fibrosis.
Waste time for her, yes.
Okay.
Waste time.
Thank you.
I think it was waste time.
Thank you, Mubashir. Now we go to Professor Khater. We know, Khater, that this disease is a fatal disease, and at the start, the patients and the parents and the doctor are worried about the health of the life of the child, and are not taking care of hearing or any other neurological sequelae. But after some time, everything is starting to improve, and then we have to start to look for the hearing loss. So in your opinion, Professor Khater, what is the best time to look for a hearing loss?
Thanks, Professor Fathi, to give me the chance to share this webinar regarding hearing loss in post-meningitic. As we know, hearing loss is a common and expected complication of cases of meningitis. So it is mandatory to do hearing assessment for ear children who have had hearing loss, regardless of the pathogen, as early as possible. This is very important and must be not discharged before hearing assessment. So hearing assessment is mandatory for any case of meningitis.
So you say that before discharge, you should have a test, or at least we have to tell him to go to audiologist right away after the discharge if the hospital is not well equipped with hearing tests. Yes. What are the hearing tests we order? We order for an infant less than 1 year.
in infant less than 1 year, we are seeking for objective test battery because the patient cannot, the infant cannot give a conventional response. So objective test battery is done, including first is tympanometry is essential to excluding any abnormality of the middle ear. Acoustic reflex is very important. Autoacoustic emission. So autoacoustic emission and acoustic reflex are must be done in any case of meningitis, and accordingly we go for further audiological evaluation as frequency-specific ABR and ASSR. Because click ABR only give an overview about the high frequency. So it's better to do click. It's better to do frequency-specific ABR and ASSR to give an idea about all frequencies of the hearing band.
Khater, can we be, of a practical point of view, do an autoacoustic emission and tympanometry and stapedial reflex? And if the child is okay, that's it, we finished. If there is any problem in autoacoustic emission, we can go for ABR, and then if the ABR is negative or does not show any response, we can go for frequency specific. Because at the first test, I think we have to say if the child is hearing or he has hearing loss or not. Can this be practical?
Yes, Prof, because but we don't depend only on autoacoustic emission, as normal autoacoustic emission doesn't mean normal hearing. So it's better to do autoacoustic emission as well as acoustic reflex to excluding another possibilities of hearing.
You know, autoacoustic emission can be done without anesthesia. It's a rapid test, it's a quick test with a stapedial reflex. And if these both of them show a normal response, we don't have to do an ABR. Am I right, or this is not a logical?
But this, in this case, we need also to do, as I said, acoustic reflex,
yes,
and regular and continuous follow-up.
Of course, continuous follow-up will be an important point.
Yes.
وائل ما بيغيرش. Can you change slide, please? Next slide. Now, if the tests show no hearing loss, what you are going to write in your report, the child is completely normal. What you are going to write in the report, you are going to write he is normal and that's it, or what you are going to say?
Yes, as we said, hearing loss is expected in any case of meningitis. So normal hearing loss doesn't mean that we lose the patient. So it's highly recommended to regular follow-up of the patient at 1 month, 3 months, 6 months, as hearing loss can occur early in the bacteremic phase or in the first few months or up to 4 years post-meningitic. So close and regular follow-up is highly recommended in this case.
So you are saying that for the first year you are following every 3 months, more or less. And then after that you follow it yearly or every 6 months. But usually the most common conditions occur in the first year. Usually if there is something, usually it occurs in the first year. So being normal in the first months does not mean that the child will be normal always. And we have to stress to the parents that they should follow the child or the infant till he is 1 year. Sometimes we have cases with fluctuant hearing loss. It's a meningitis, but fluctuant, and they come and go. Do you see such cases, and do you give steroids for such cases, or what you do, Khater?
A fluctuant hearing loss also can be expected in case of meningitis, so a regular and close follow-up is highly recommended, and this is depending on the case itself, so it differs from case to case. In case of fluctuant hearing loss, it is recommended to give steroids as anti-inflammatory with regular follow-up, and according to the results, we can proceed for further recommendations.
Okay. Dr. Adel, is it important to call the pediatrician and ask him about the results of the culture and sensitivity of the CSF, or it doesn't surprise you?
Yes, sure. Because we found culture. We'll make that close patient and regular follow-up and serious follow-up is important such case.
Okay. So the pneumococcal meningitis is very notorious of being one of the most common causes of ossification, and this is why we have to look for the results of culture of sensitivity. Dr. Mahmoud Mandoor, do you do MRI for a patient with meningitis and normal hearing?
No, I think we don't need to do MRI if there is a normal hearing, because there is no affection to the cochlea without affection of the hearing.
Okay.
As long as there is no hearing loss, so you can be sure that there is no inflammatory exudate inside the cochlea. So there is no need for MRI in normal hearing.
If the child has hearing loss more than 30 decibel, what is your recommendation?
Actually, in such a case, this is a matter of debate, because, of course, here there is a chance for hearing aid. So the audiologist may suggest using of the hearing aid, but our concern as a surgeon that the condition may progress to cochlear ossification, so I can lose the cochlea, and I need to do CI before losing the lumen of the cochlea. So a very reasonable choice in such a case is to do the gadolinium enhanced T1 weighted image. If you find there is an enhanced signal in the cochlea, we can expect that there is an inflammatory exudate inside the cochlea, and the condition will progress to fibrosis and even ossification. So in such a case, I can proceed with CI. But if you find that there is no enhancement in the cochlea, this indicates that there is no inflammatory exudate, and I can expect that there will not be progressive ossification. In such case, I can follow up with regular hearing evaluation and hearing aid.
So I will recapitulate in my words and just correct me if I understood right or no. So if the child has hearing loss, we have to do imaging first. Yes? Yes or no?
Yes.
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 When we do image, we are going to do an MRI. We don't have to do CT scan from the start. We do an MRI.
No.
And if we show ossification signs by T1 and T2, as we are going to mention after a while, we are going to be debatable between either hearing aid or cochlear implant, depending on the situation of the MRI. If there is signs of enhancements also, which means that there will be progressions, you are favorable of CI. If not, you are going to recommend cochlear and audio and hearing aid.
Yes.
So, but Dr. Mubashir, but if now the child is presenting with hearing loss more than 70 decibel, do you give the chance of hearing aid, or you go away straight away for
cochlear implantation?
For cochlear implant?
Yes.
So
the universal or is if he can offer tools bilateral cochlear implantation.
Okay. By the time we are going to arrange for the next presentation by Professor Mandoor, now we'll have 5 minutes, and in these 5 minutes, I'm going to summarize what has been said until now. Now I'm going to summarize until they just prepared the next meeting. The salient points we have said in this first half an hour, that we have to encourage the authorities to have compulsory vaccination among the 3 organisms: Haemophilus influenza, Neisseria meningitis, and special streptococcal pneumonia. The second point, we have to discuss with our fellow pediatricians to start steroids very early, half an hour before antibiotics, because they found that this was a game changer in the prognosis of hearing loss after meningitis, or whether it's going to have hearing loss or not. And then after that, we moved that we have to do the test before discharge better, and if not, just immediate after discharge. And it's better to have in written. You give the paper in written to the parents that they should have the test very soon. And from a practical point of view, we can use an autoacoustic emission, which is a rapid test with a stapedial reflex. If they are good, it's enough. If not, we can go for ABR. And then we went for the MRI. Of course, if he has no hearing loss, we don't do an MRI. But if there is no hearing loss, we don't do MRI. And if there is hearing loss, we go for an MRI. We don't do CT scan from the beginning, because if the MRI is fine, we don't have to do a CT scan. However, the MRI, as Dr. Mandoor is going to explain now, if it will show any abnormalities, we can go after that to look for the CT to differentiate between fibrosis and ossification. Now, thank you for waiting for this break, and then we have the pleasure to introduce Dr. Mandoor, Mahmoud Mandoor, Professor Mandoor. He's going to give just a review on the meningitis, imaging in meningitis case. Professor Mandoor, please.
Thank you, Dr. Fathi. We will talk about radiological finding in case of meningitis-induced hearing loss. By the end of these presentations, we should be able to answer these 4 questions: how to do imaging and which modality to use, what about the radiological finding and the clinical implication. How to do imaging: it's recommended to do imaging within 2 weeks after hearing loss has been documented by audiological evaluation. What's about the modality? The 2 standard modalities are the MRI and the CT. Review of literature revealed that sensitivity of MRI has been found to be superior than CT in detecting cochlear changes in case of meningitis. CT has to be done as a complementary modality, as we will see in the next few slides. What about the modality of the MRI? Our gold standard is the heavily weighted T2 weighted image, whether it's 3D Viesta or CISS. The other modality is the gadolinium enhanced T1 weighted image. Now, let's at first remember the normal shape of the normal cochlea in the MRI. This is an axial view. This is a heavily weighted T2 image, axial view. As we can see here, this is the vestibule, and this is the lateral canal, the characteristic signaling appearance, and this is the shape of the normal cochlea, ascending limb of the first term, and this is the descending limb. As we move downward, now we can see the basal turn of the cochlea, and the ascending limb of the basal turn, and the descending limb of the basal turn, and the middle turn. This is the posterior semicircular canal. As we can see here, normal cochlea appear as hyper-intense signal or white signal due to its fluid content. As we move further downward, here we can see the basal turn of the cochlea. And of course, this is also the posterior semicircular canal. Now let's see the coronal image. As we can see here, the superior and the lateral canals and the vestibule. As we proceed from posterior to anterior, now we can see the beginning of the cochlea, and this is the rest of the cochlea. As we can see here, we can trace the whole turn of the cochlea to make sure that there is a homogeneous hyper-intense signal in the whole cochlea, as we can see here. This is also an axial view, 3D Viesta or high resolution heavily weighted T2 image. As we can see here in the high resolution image, we can even saw the post compartment of the basal turn, the scala vestibuli in the anterolateral part, and the strip of the scala tympani in the posterior medial part. Again, this is another view at higher position. This is the ascending limb of the first term with its 2 scala, descending limb with its 2 scala, and this is obvious, the 2 turn or the 2 scala of the middle turn of the cochlea and the apical turn. Now let's take a look about the sequence of the radiologically change inside the cochlea as the pathological process proceeds. We can divide the meningitis-induced cochlear change into 3 phases: acute phase and intermediate phase and the delayed phase. The acute phase starts from the insult of the meningitis, and it will persist for up to the 8th week after the onset of the disease. During the acute phase, as we can see here, the gadolinium enhanced image will show a high signal, while the T2 image will show normal cochlea because there is still fluid inside the cochlea. The intermediate phase, which can start as early as the 3rd week and end by the 10th week, here in the intermediate phase, again the gadolinium will still show enhancement, but also the T2 image will start to show its interruption of the signal or even loss of the signal. This is due to beginning of replacement of the fluid with fibrous tissue. Then the last phase, which is the final phase, in such case, active phase has been terminated. So the gadolinium enhanced image will show negative results. There will be no enhancement with gadolinium. But in the T2 weighted image, here we can see the actual replacement of the fluid by the fibrous tissue, which appear as interruption or absent of the signal. This is a radiological finding. Again, this is a T2 weighted image, heavily weighted T2 weighted image. This is what we call the grade A or the normal cochlea. As we can see here, there is a homogeneous hyper-intense signal in the pulse scala of the cochlea. Here, we can see there is start of the interruption of the signal in the basal term. This is what we call grade B. In the grade B, there is a start of displacement of the fluid, so there will be patchy interruption of the signal. As the condition progresses, there will be complete replay of displacement of the fluid and distribution is matter exudate, so the signal will appear to be homogeneously faint or noisy signal in the cochlea. This is the grade C. Then, as the condition proceeds, there will be complete loss of the fluid signal or the grade D. This is regarding the 3D or the T2 weighted image, heavily weighted. Now let's talk about the gadolinium enhanced image. As we can see here, this is a gadolinium enhanced T1 weighted image. As we can see here, there is no enhancement of the cochlea. This picture actually has been taken in the very early phase, within few days or week after the insult. But as the condition proceeds, the inflammatory exudate will start to appear in the cochlea, so the enhancement will start to appear in the cochlea. Later on, there will be a hyper-intense signal or marked enhancement of the cochlea with gadolinium, indicating that there is diffuse inflammatory exudate distribution inside the cochlea. This is a case, as we can see here, this T2 weighted image, 3D Vista or heavily weighted T2. As we can see on the left side, there is no signal in the T2. In comparison to the other normal side in which there is a preserved cochlear signal. In the T1 weighted image, gadolinium enhanced T1 weighted image, we will see the reverse. As we can see here, the pathological cochlea will show enhancement with the gadolinium, indicating that there is inflammatory exudate inside it, while the normal cochlea on the left side will show no enhancement because it contains only fluid. There is no exudate. This is the same patient but at higher view. As we can see here, again, this is the normal cochlea, but this is the ascending and descending limb and the middle term. Here there is the pathological cochlea with complete absence of the signal, grade D. This is the gadolinium enhancement. Again, on the normal side, there is no enhancement, but in the pathological side, there is a diffuse enhancement of the whole cochlea. Another case, as you can see here on the left side, there is a normal signal of the cochlea. On the other side, there is absent signal of the cochlea. Here is another important aspect I want to highlight. If you're looking for the meningitis-induced hearing loss, you should not only look to the cochlea, you should also look at the vestibule. As we can see here, this is the lateral semicircular canal. The signal of the lateral semicircular canal here is interrupted. On the other side, there is no signal at all from the lateral semicircular canal. It's a very common finding that with the meningitis-induced hearing loss, you can see also fibrosis even in the vestibule, especially in the lateral semicircular canal. Another case, as you can see here, complete absence of the signal of the cochlea, interruption of the signal of the vestibule. Here in the T1 weighted image, even without gadolinium, you can see here there is a high iso-intense signal. It's not a hyper-intense, but iso-intense signal, which is not normal. Normally, you should not see any cochlea. But here in that case, we have seen inflammatory exudate with rich protein content, so it appears as an iso-intense signal in T1. To be more sure, there is the gadolinium enhanced T1 weighted image. As you can see here, there is enhancement of the vestibule of the left side. Of course, there is the lateral sinus appear hyper-intense due to the contrast. What about the CT? To know about the importance of the CT, let's use that example. This is a T2 weighted image for a patient with no signal in the cochlea and very faint signal in the apical term. This is the CT picture of such patient. As we can see here, there is a hyper-dense opacity encroaching from the modulus upon the descending limb of the first term and the middle term. So we can expect here, as there is no signal and there is hyper-intense opacity in the CT, so the absence of the signal in the cochlea is due to ossification. There is actual replacement of the fluid by osseous tissue. Another example, again, this is 3D Vista or heavily weighted T2 weighted image with loss of signal of the cochlea. This is a CT picture of such a patient. As you can see here, there is a preserved patency of the basal term. So we can expect here that the absence of the fluid signal is due to its replacement, but by fibrous tissue, not by osseous tissue. It will affect our decision in the CI surgery. So this is the rule, one of the important role of CT in the decision making in CI in meningitis-induced hearing loss. Of Also, again, the other important factor is the staging of the disease according to the CT. Now let's talk quickly about clinical implication. The gold standard has been also that the diagnosis of bilateral profound hearing loss, whatever the imaging result, is an indication for CI. Finding of imaging result of replacement or absent signal of the cochlea or cochlear ossification is an indication for the CI, whatever the degree of the hearing loss. Now, let's talk about this example. A case of post-meningitic hearing loss with moderate hearing loss. MRI finding, as we see here, complete absence of the signal of the cochlea at its basal term. But in the middle and the apical term, there is a preserved patency. So I can expect in such patient that there is ossification or fibrosis of the cochlea in the basal term, but the middle and the apical term are still preserved. I can proceed with CI, but this patient has a moderate hearing loss. This is the debatable question, or this is the debatable situation. Should I leave this patient with hearing aid, or should I proceed with CI to save the rest of the cochlea? As we mentioned earlier, this is an indication of gadolinium enhanced T1 weighted image. As we can see here, there is the two axial cuts. One at the basal term with absence of the signal, another at the middle and the apical term with preserved signal. Let's look at the T1 weighted image. As we can see here, at the basal term, there is enhancement of the cochlea, indicating that there is inflammatory exudate in the basal term, which could explain the absence of the fluid signal. But in the middle and the apical term, there is no enhancement. This indicates that there is no inflammatory exudate in the middle or in the apical term. So I can predict that the condition will not progress to the middle or to the apical term of the cochlea. So I can decide in such a patient to proceed with the hearing aid and wait or with regular follow-up of the hearing. And actually, this matter has been studied in a very interesting review of literature, and then a paper has been published in the literature, and they found that all the cases that show no enhancement in the rest of the cochlea will still have no enhancement and no pathological change for a longer period of 2.5 years. So this is a very good predictive tool to help us in decision making whether to proceed with CI or to use the hearing aids, especially in cases with moderate hearing loss with usable hearing aids. Thank you.
أنا على الفيديو أذكر. Now, thank you, Professor Mandoor, for this very illustrative, comprehensive overview of the imaging of cases of meningitis. Thank you very much for that. We appreciate. Now, chair our وائل حط السلايد بتاعتي.
احنا مكملين هنا يا فتحي؟ ها؟
Just a moment, please. We are now on the air. Now we finish the imaging and then we go for the slide اللي بعد كده. Now, what to do after that? How to do the cochlear implant? And this I'm going to discuss it with our eminent CI surgeon, Professor Rashad Ghunaim. Professor Rashad, you are going to tell us the different grades of the ossification and what you do in every case. So please, Dr. Rashad,
yes. Yes. Good morning, my colleagues, my chairman, Professor Fathi, for this nice presentation. This is a grade 0. There is no ossification of, at the round window or a basal term of the cochlea. In this case, we deal like standard cochlear implant.
So this is grade 0 and you are going to do it as a normal cochlear implant.
Yes, okay. Yes. Just we approach the round window,
yes,
remove it for hand, and insert the tooth through the round window.
As a conventional cochlear implant. And
yes.
What about this case, Dr.?
This is a type 1A. In this case, this ossification at the round window only with normal scala tympani of the basal term. We just drill the round window and it proceeds like a classic cochlear CI. But for insertion of the electrode, standard electrodes and the prognosis is like a normal standard cochlear implant.
So you consider it as a relatively easy condition.
Yes, it's easy.
This
is the
case, Dr. Rashad?
Type 1B, in this case, ossification or alterations at the round window and the proximal part of the basal turn of the cochlea. This nice illustrations from cochlear implant surgery book of the Magnus Emma, cochlear implant and other implantable devices. It's a very nice book.
Okay.
In this case, also we drain the bone, the ossified bone, the cochlea from the round window to and the proximal part of the basal turn to get a lumen of the basal of the skeleton benign without drill out.
In most cases, you can reach to drill this part and then we can insert our implant.
Yes, we can use in this case extended vestibular approach. Okay. In this case.
What about this grade 2?
This grade 2 ossification in which all the skeleton, the basal turn of the skeleton benign of the basal turn obliterated or replaced by ossified bone. In this case, the approach in this case we use also basal-tympanotomy or extended basal-tympanotomy.
What do you mean by extended posterior tympanotomy? What do you mean by extended posterior tympanotomy?
Extended basal-tympanotomy, either extended inferiorly and sacrifice the cochlear nerve, or superiorly we remove the patrus and remove the incus.
You can remove the incus to get a better access. Okay.
Yes. Yes, and in this case, the standard or the ideal or the best option is scala vestibuli insertion to avoid more drain out and we can preserve the residual hearing. But the drawbacks here is the incidence of vertigo increase after surgery.
Of course, the scala vestibuli, you have to go a little bit superiorly than the normal round window. So you have to go superior a little bit so that you can go to the scala vestibuli.
We have anterior to the tegmen. Anterior to the tegmen.
Okay. The third.
In this diagram, this is the type grade 3A. Ossification or obliteration of the scala vestibuli and the scala tympani.
You have both of them
with reassembling basal turn.
Okay.
In this case, the best approach is subtotal vitrectomy to have a good exposure and to avoid complications.
Okay.
We drain out basal turn, or the best for me is the middle turn cochleostomy.
Can you give us the landmark of the middle turn cochleostomy? The landmarks for your middle turn cochleostomy. Where you
yes, the landmark is we go superior to the oval window 2 millimeter
anterior
and
to the
just
oval window and just inferior to the tensor tympani.
Process and use 1 millimeter down of the bear.
So better look at just anterior to the oval window and just inferior to the tensor tympani, and you go vertical to drill your middle turn cochleostomy. Okay?
Yes.
And what about that? This is 3B, where you can.
3B. This is the great. This is the great. This 3B.
Yes.
3B obliterations of the basal turn and ascending basal turn. Approach also subtotal vitrectomy and the same drain out. When we can use here also middle turn cochleostomy.
Middle turn cochleostomy, or you can do both the middle turn and some drill out. Okay.
Yes.
And what about that? The fourth case.
This is great for total ossification of the cochlea. If you do drill out, we should use subtotal vitrectomy approach to avoid complication. Here, the most important is the coronal artery.
Okay.
But the best is ABI acoustic brainstem implant.
First,
translucent
about
approach.
the carotid artery, we have to be very cautious because anteriorly there is a carotid artery, so you
Yes,
shouldn't go
yes.
far anteriorly more than 8 millimeter. You should be, you should do not go away in front of the tendon of tensor tympani. And if you see some bleeding, some small bleeding, it could be from the vasa vasorum of the carotid. So all these are warning signs to avoid any injury of the carotid artery. There is a controversy, Dr. Rashad, whether the ABI is better or the drill out is better. But what
I think in the ossified cochlea, the drill out usually carries a poor prognosis. The result after this is not so satisfactory.
the outcome in both conditions is not very good. Thank you for this very nice roadmap, Dr. Rashad. Now I'm going to ask Dr. Mubashir. I know that you are fond of subtotal petrosectomy. Can you tell us what are the advantages of subtotal petrosectomy, Rashad? Mubashir? Dr. Mubashir? Mubashir, Dr. Mubashir, can you hear us? Dr. Mubashir? Dr. Rashad, can you tell us why the subtotal petrosectomy give you better access?
Yes, this is a very good exposure, and we can avoid complications to the facial nerve, carotid artery.
And in the meantime, when you obliterate the cavity, you can compress the electrode and
yes,
secure it.
obliterations of the electrode insertion, obliterated by the muscle and of fat, and I think it's a safe approach.
Dr. Adel, can you hear us, Dr. Adel?
سامعك سامعني؟
Yes, can you tell us which electrode usually use in cochlear implant?
So in such cases, we expect resistance to fibrosis. We prefer to use firm electrodes, the stylet, electrodes stylet, and in rare cases, we use a double array electrode.
Okay, so you prefer usually a firm one which can bypass the fibrosis and the ossification. And about the double array, I think there were two companies which are doing that. One of them, I think they stopped it, and the other one, they do it per request, and the request will take 3 months. So I can see that this could be somewhat impractical in case of meningitis.
Yeah, yes.
Dr. Mubashir is back or not? Dr. Rashad, if you have a case of meningitis and you don't have the electrode in your hand because of any reason, can you advise putting a dummy electrode or you don't advise to
No, I don't prefer dummy electrodes because dummy electrode create fibrosis and it's very difficult to remove this electrode during the surgery.
So at one time we were using this dummy electrode, but we realized that it could be more harmful to the patients. Dr. Mandoor, can you hear us?
Yes, sir.
Yes, okay. You know, usually these cases are below 8 months, and the anesthetists have a lot of problems to deal with this patient. Can you help him by a way or another in your technique? Because one of the problems he has is the bleeding from the diploic bone. How you manage this bleeding in diploic bone?
Actually, in such a case, we use a couple of tricks. For example, by while washing, we may use a saline diluted with adrenaline or diluted in saline. Also, we can use hypotensive anesthesia in such cases if the patient, the condition of the patient allow, and of course by using the diamond, it will be more helpful
you have
controlling
the diamond to try to stop as much as you can.
Yes.
And Adel is back. I don't see Adel. Adel is back.
أنا سامعك سامعك.
Okay, yes, we hear
Yes.
you. We hear you.
Yes, we hear
The facial nerve is usually superficial. How you are going to put your incision?
If the surgeon prefers end-oral incision, there's no problem. If he's planning to do post-rectal incision, the incision must be high above the facial, the end of the facial exit from the stomach tree.
Okay. At the end of this meeting, I would like to thank all the panelists. They were very concise, very informative. Thank you. And I would like to thank all of you who had taken the time to see us. And you can watch this video, or if you didn't watch it from the beginning, on the same channel. You are watching it for 1 or 2 days, and then it will be on this channel. So, and I hope to see you in our next presentation for cochlear implants. We will announce the topic and the date later on. Thank you, and happy Ramadan, happy feasts, and stay safe, stay healthy, and see you soon with the return of tourism. Okay, bye-bye.